Good evening and welcome to tonight's webinar presentation. My name is Dr. Russell Burgum. I am a physician specializing in interventional orthobiologics with Regenexx in Des Moines. And tonight's talk is a continuing discussion on how to reduce pain and avoid surgery with non-surgical treatments for orthopedic conditions. We should have plenty of time for questions at the end, and hopefully you find this to be engaging and informative. That is our goal. So just briefly, interventional orthobiologics is the specialty using high-tech, high-resolution imaging devices such as an ultrasound machine that you can see on the left here, or a fluoroscopy, which is like a real-time X-ray machine on the right, to guide injections into disordered or degraded orthopedic injuries or conditions such as joints, tendons, and ligaments. And orthobiologics refers to the fact that we use your own tissue, your own cells, and not things like steroid injections. Sorry, I'm going a little too fast here. So Regenexx is actually where stem cell injections were invented. The first human stem cell type injections were done in 2005 at the Centennial Schultz Clinic in Broomfield, Colorado. This whole idea of interventional orthobiologics is a new specialty, really come into fruition probably in the last 10 years, when it was initially more referred to as interventional orthopedics, and with the focus on using only the patient's own cells, we kind of changed the name to interventional orthobiologics. So what does this mean? It's the core tenets of our specialty are that we use injectates to facilitate healing of bone and tendon and ligaments, which also help alleviate pain, which is in contrast to the broad use done currently in the medical fields of using steroids to control pain. Steroids will help with the pain. For instance, if you have arthritis in a joint, it'll help with arthritis pain, but there are numerous studies showing that steroids used at the doses that are given in orthopedic and primary care and sports medicine clinics around the country are toxic to cartilage cells and to tendon cells. They actually accelerate the progression of your arthritis. So we don't use that. And we use very precise placement of these injectates into the damaged tissue with imaging guidance such as ultrasound and fluoroscopy. So most people have had, at least once you get to a certain age, most people have had some type of injection into a joint. And 95% of US physicians who do injections will do simple injections that are going just into the joint, intra-articular joints, injections, usually one shot placed in the joint, usually not with any type of guidance and any type of ultrasound or fluoroscopy guidance. And then a small portion of physicians will use guidance such as ultrasound or fluoroscopy to guide injections. And generally these are steroid injections. But interventional orthobiologics represents only about 1% of the US physicians. Now, when I do an injection into a joint, or I should say when I'm injecting a joint, I don't just inject it into the joint itself. We treat the entire physiologic functional unit, the functional structure of a given joint, which would include injecting into, for instance, like in the hip, the ligaments around the hip, the tendons around the hip, the iliotibial band. In the knee, there's numerous tendons, and ligaments, supporting structures that give the joint stability. Because if we just address the pain and don't address the underlying instability, you don't get to the root cause or some of the root causes. You need to have a stable joint to help prevent it from wearing down. So when I do a knee procedure, the patient may have 8 or 9 different structures injected, including their ACL or their ligaments or the quadriceps tendon and patella tendon, their hamstrings. Similarly, in the shoulder, there are numerous tendons in the shoulder, the rotator cuff tendons. They're the supporting ligaments deep in the shoulder that hold the ball in alignment with the socket, called the superior glenohumeral ligament, the middle glenohumeral ligament, the inferior glenohumeral ligament. And these are all things that we inject as needed to address the entire joint. So we're very different at Regenexx clinics from the other, quote, stem cell clinics that you may see around the country. We're all highly trained physicians, board specialized in our different areas. I am board specialized, well, first was in family medicine, then in sports medicine, and then I am board certified in diagnostic musculoskeletal ultrasound. So we're highly trained and all doctors in the Regenexx network of clinics also go through additional interventional orthobiologics training, as well as Regenexx specific training on how Regenexx clinics, Regenexx physicians do their techniques, do their procedures differently, and how to process your blood and bone marrow products in the lab, because we have a very highly specialized lab procedure for processing your own cells to be injected. And we're supported by a multi-million-dollar research lab at the Moines clinics in Colorado, where they also have a fellowship program where they'll train one physician for an entire year. And so a small portion of the Regenexx physicians are actually Regenexx fellowship trained. And one of the biggest things that we have is we have the world's largest orthopedic outcomes database. So if you've ever had an injection at a non-Regenexx clinic, there's a pretty good chance that you were not asked to fill out a survey enumerating your pain level, your function level, and going through numerous questions asking you about how does this affect your life and how does it affect your daily activities. But whenever a procedure is done in a Regenexx clinic, we first ask you to fill out this baseline survey. It takes about 5 to 10 minutes. Then after the procedure, you'll get similar surveys at 1 month, 3 months, 6 months, 12 months, 18 months, 24 months, and every year for 20 years thereafter, as long as you keep filling them out. And what we do is we track all that data to see what joints and what types of procedures work and for how long do they work, and in what patients do they work, what degree of breakdown can we actually treat. And so therefore we have the world's largest orthopedics outcomes database, and we use that daily to help determine whether a patient is a good candidate or not for a procedure, because we don't want you to go through a procedure that we don't think that the data shows you have a very, very poor chance of having a good outcome. We want you to have a great outcome. We want to do procedures that are going to work, and we use the science, we use the data to help make those decisions. So we do precise image guided procedures of MSCs, that's short for mesenchymal stem cells, and BMAC is bone marrow aspirate concentrate. That's where we get those cells. And we use platelets from your blood to treat head pain, neck pain, upper back pain, shoulder arthritis, rotator cuff tears, shoulder laxity and instability, thumb and wrist problems, carpal tunnel syndrome, sciatica, hip arthritis, knee arthritis, meniscus tears, ACL tears, ankle arthritis, foot and toe problems. So we can treat things from head to toe at the various Regenexx clinics. So I mentioned we have this outcomes database registry. We started tracking cases back starting in 2005, and we currently have 19,343 cases that we're tracking for knee procedures, and lumbar spine are over 14,000. And as we work our way down, shoulder, hip, cervical spine, this is kind of the order of the most common to least common procedures that we do and track. But we have almost 70,000 cases that we're tracking. So here are some examples of what is involved with interventional orthobiologics. So over on the left here, this shows a machine called a C-arm or a fluoroscopy machine. And this is what we use to take real-time x-rays like what we're seeing in the upper right here. This is a view of someone's knee with the kneecap or the patella here and the femur down below. And that's lining up with an MRI image of that patient. And in that MRI image, what we're looking at is the healthy bone. This is the thigh bone or the femur, and this is the patella. Healthy bone is dark, but areas of bright white here represent swelling or bone marrow edema, or we call them bone marrow lesions. And that's area where the bone marrow is actually dying, and that is treatable. And we want to treat it because the cartilage on the surface of the bone, so cartilage is along here. This black little line is contrast dye showing that the needle is in the joint space. This is a bone trocar actually going into the bone to treat this bone marrow lesion. But the cartilage gets its nutrition through the bone marrow. And if you have bone marrow lesions, you get reduced nutrition to the cartilage, and that is a predictor of rapidly progressing arthritis. And there have been numerous studies shown that you can treat this and actually resolve that bone marrow lesion and help prevent progression of arthritis. So another thing is we can inject the ACL, the anterior cruciate ligament, in a patient's knee with that has tears. There are two bands of the ACL, and we can address both of those using fluoroscopy. These are fluoroscopic images showing contrast dye flowing along those bands of the ACL. We can treat superior labrum tears in the shoulder. This is a shoulder joint with fluoroscopy images showing the labrum is the lip of cartilage up on the edge of the socket, and here's the joint. And this is an ultrasound image showing a patient's wrist, as if we're looking at it kind of straight on like this, as if you look straight on and then take a image slice. What we see here are the wrist tendons, and this is the nerve called the median nerve. That's the nerve that gets impinged or damaged in carpal tunnel syndrome. And we have a treatment where we extract the growth factors from platelets, and we call that platelet lysate modified, and we bathe that nerve with an injection of that fluid all around the nerve to help heal the nerve, to provide nutrition to the nerve, and help to break up any adhesions where this nerve may be stuck to the tendon and surrounding tissue around it. And that is something that we do quite frequently as well. So why would this replace elective orthopedic surgery? Well, one, it's less invasive. We can do this in a procedure room. You don't have to go to the hospital. We don't make any incisions. It's all using needles. We have quicker recovery. Patients get up and walk away from the procedure room. We encourage you to move around and stay active after the procedure, and you preserve your biomechanics. You keep your own body parts. So there are different things that we use. There's growth factors, there are cytokines and stem cells, and they're basically healing or growth promoting factors that come from your own cells that we can extract from platelets or from your bone marrow. And growth factors are like concentrated espresso type shots that kickstart your healing, and cytokines are messengers. They're chemical signalers that cells signal to other cells to to come on in and help heal an area or to help reduce or clear out inflammatory chemicals. And then stem cells are, I mentioned before, MSCs, mesenchymal stem cells, are, imagine them as like the general contractors at a construction site, and they direct all the other cells in the area to go help repair this, go repair that, and they block pain signals from leaving the area. And then when all is done, some of them can actually turn into new cells, such as cartilage cells. Another real common orthobiologic that we use is called platelet-rich plasma. So we probably use this depending on the practice kind of focus area of the different clinics. It could be anywhere from maybe 60% of the procedure cases up to 80% of the procedure cases may use only platelet-rich plasma without using any bone marrow. So what is platelet-rich plasma? Well, our blood has many different layers, many different components to it. So if we take your blood in a vial and spin it on a centrifuge to separate out the different layers, your blood will layer out into a heavier layer of red cells and a layer of white cells. And then what's left is a clear, kind of light yellow colored layer of the blood that comprises maybe 30 to 50% of the blood, called the plasma. So when we separate out the red cells from the white cells, what the platelets in your blood, which are tiny cells that are used for healing and to help stop bleeding and to help repair cuts and other tissues, the platelets are mixed in with the plasma. So if we take lots of blood, separate out all the red cells and the white cells, and we're left with a lot of plasma with platelets distributed all throughout that plasma. Then we take that plasma with platelets all distributed through it, and we concentrate it again and separate out all those platelets into a very small volume of plasma. So it's super concentrated. And that's where the term platelet-rich plasma comes from. And so that super concentrated platelet-rich plasma is what we inject into different parts of your body, such as your joints or tendons or ligaments, to help heal the disordered tissue or damaged tissue. Platelets do this by releasing numerous growth factors to signal other cells to start healing. They also release growth factors that will signal other cells to migrate into the area. Platelets are what's used, for instance, like when you get a cut. If you cut your skin, it's the platelets that start the coagulation cascade that stops bleeding and forms a clot, and then a scab, and then new skin. Platelets also activate or stimulate stem cells that are in the area. We have stem cells throughout our body and all of our different organ and muscle tissue and tendon tissue, and they're kind of hanging out, waiting to repair things that is needed. And when platelets are released into the area, they stimulate stem cells. So there's another thing called platelet lysate, and we use that frequently along with regular platelets. So imagine if we take all these concentrated platelets and break their cell walls and release all of their growth factors. That is called platelet lysate, and we have an additional way of releasing them, and therefore we call it platelet lysate modified. That is what we use when we're treating injured nerves, such as in your back or your neck or in the carpal tunnel. But we also mix it in when we're treating with regular platelet-rich plasma, when we're treating arthritic joints or tendon tears or ligament tears, to give an immediate response. Because platelets, when we inject platelets into an area, the platelets will release those growth factors slowly over the course of 7 to 14 days. So platelet-rich plasma you can imagine that as like an extended release medication, and platelet lysate is like an immediate release medication. So I mentioned growth factors there. This picture here shows some of the many growth factors that are released from platelets when we inject them. And this helps explain why they're so potent, why they can actually help heal tissue. And recent studies published this year actually would indicate would lend proof to the fact that platelets are actually platelet-rich plasma is actually considered a disease-modifying medication now. It actually can change the course of the disease by activating these numerous growth factors. Then we have stem cells, and stem cells, that's the, kind of the lay term for MSCs. And we isolate and concentrate those cells from bone marrow concentrate. We aspirate that from the back of your pelvis, off the what's called the iliac crest, and I'll show pictures of that later. And they're very potent stimulators of healing. All of these procedures that we do are the whole idea is they stimulate your body's own innate healing. So they're not like magical pixie dust that suddenly gives you a new joint, a new 8-year-old child's quality joint. They stimulate your own innate healing. And bone marrow cells have bone marrow concentrate has a small percentage of cells in them that are called MSCs. And there are other potent lines of cells in the bone marrow aspirate that promote healing as well. And we use the bone marrow aspirate with MSCs in it for more advanced arthritis or higher grade tears of tendons or ligaments. And we can, just like with platelets, we can concentrate your platelets to a much higher dose or much higher concentration in the lab than all the other clinics, including some of the world famous clinics around the region. We can concentrate them to a higher dose, a higher effectiveness than all these other clinics can do. And we can do the same thing with your bone marrow. And we concentrate that and extract the healing layers in our own lab on site immediately after it's been aspirated from your body. I would encourage anyone watching to go to the main Regenexx site. You could go to regenexx.com and search on Dr. Centeno, Centeno blog. He publishes a blog every day that has great information on it. And today's blog, he just published a research study showing what we have been saying at Regenexx clinics for decades now. But there's a new research study proving that we need higher concentration of platelets the older the patient is. And so that brings up one of the benefits of being seen at a Regenexx clinic, and that we can concentrate your platelets to the appropriate level, which is if you're over the age of 50, we may have to concentrate your platelets to 20 times the normal concentration that's in your blood. Well, all these different other clinics around the country, they're limited by the processing kits that they buy from device manufacturers, medical device manufacturers, and the worst kits concentrate your platelets to maybe 1.5 to 2 times your platelet concentration normally found in your blood, and the best ones are maybe 6 times. Now, for patients who are 30 years or younger, the studies have shown that the benefit of concentrating your platelets kind of tapers off when you start getting up around 5 to 6 times your normal concentration for young people. But for older people, and over 30 isn't that old, the more we concentrate it, the better. And that a lot of that has to do with the effects on how platelets stimulate your stem cells. And Dr. Centeno's blog talks about that today, about how the higher dose concentrated platelets stimulate stem cell activity and stem cell growth much more in elderly patients. And elderly, like I said, I'm talking over age 30. So middle age and beyond, we need higher concentrations. So, and we can provide that. So people often have a lot of anxiety about, well, what is this bone marrow draw? I hear from my friends that bone marrow biopsies are extremely painful, and everyone's heard stories of cancer patients having extremely painful bone marrow biopsies. And so I want to show some pictures of what a bone marrow trocar actually looks like. In the middle, this shows one similar to ones we use in our clinic. This is a thick needle with it has, if we look over on the left, this is the hollow outside part. This is the inside part that has a sharp point on it, and this piece slides right in the middle. Oh, going too far. Slides right in the middle of this. And so we use that to bore into the bone. And once we get into the bone, we can pull out the centerpiece and then attach a syringe. Like here over on the right, there's a syringe attached to the bone trocar, and you slowly draw back and bring some of the bone marrow out of the back of the pelvis. So that's called BMA, or bone marrow aspiration. It's a sterile technique, sterile procedure. We use sterile gowns, sterile surgical drapes. We scrub the patient just like they're having surgery. And in our clinic, we use IV conscious sedation, and we can add IV pain medications if needed as we're doing the procedure. And patients, and I've done this with some patients who've requested no medications at all. I've done a lot of these procedures with using nitrous oxide plus maybe an oral pill like a Vicodin, and it's very well tolerated. I would honestly say maybe less than 5% of the patients that I've done this on have said they've experienced pain. And I ask every patient when I'm doing it, can you describe to me what you're feeling as I'm doing it, or describe to me what it felt like when we're done. And 95% will say it's just a weird pressure change sensation. So it's very well tolerated. So when we get that, here's more pictures showing where we get it from. So it's from the back of your pelvis, called the iliac crest. And this inlay here shows a needle. This shows kind of the area of the crest where we enter in. Over on the far right here, there's another perspective. We come in along the side of that iliac crest. And right up above, this shows kind of a zoomed in view. We have a thick, hard, not a thick, but a very dense outer layer called the cortical bone on the outside of our bone. Then inside of that, it's like a honeycomb structure. And this shows what that trocar looks like. And so when I'm going into the bone, I can feel it's a lot of pressure, and then I feel the pressure change once I get through the cortical bone. And at Regenexx clinics, we have a very kind of a unique way that we draw our bone marrow, in that we draw a little bit from one depth, and then we go half a centimeter deeper, draw a little bit more, go half a centimeter deeper, draw a little bit more, and then back out of the bone, but not out of your body, and redirect it and go into another site. And we do that at several sites, up to 4 sites on each side of your pelvis, depending on how much bone marrow concentrate we need for your given procedure. And we do this technique of taking a little bit at 3 different depths from multiple locations, because the Regenexx research labs they've studied this, and they found that we get the highest number of live cells extracted from your bone marrow when we do it in this manner. And when we do a procedure, with every procedure, we take account of what's our total nucleated cell count of the bone marrow extract for every, and we track that in our registry for every procedure that we do. So bone marrow aspirate, concentrate, BMAC. This shows, this is the backside of someone's pelvis. We get it from this thick part of the iliac crest coming in from the side. And these are the different cell lines of potent cells that we get when we extract the bone marrow concentrate. Now, when we do that, we only take a very small amount of your actual bone marrow there are 2 layers of cells that separate out when we separate them on a centrifuge that we manually extract in our lab. And the rest of the cells are blood or white cells or platelets or plasma, but it's a very small percentage of your bone marrow extract that we use to make the bone marrow concentrate, and it has all those high, very powerful cells in it. So a common question is, well, why don't these cells go to the problem areas all by themselves? I mean, they're in our blood, and you know, the bone marrow makes our cells, our blood cells, and our platelets. And it's a good question. I get that question often. But the reason is, for instance, when you get a cut in your skin has a very rigorous blood supply. So platelets become activated when they come into contact with connective tissue, such as like collagen in your skin or in a tendon. So once they come in contact with connective tissue, they release the growth factors and the healing cascade starts. The problem is cartilage, tendons, ligaments don't have a good blood supply. Muscles do, so muscle strains will heal better than a tendon or ligament strain. So we take all those healing growth factors from the platelets or the bone marrow, concentrate them into a very potent small injection, and put that exactly where the problem is. So that is why it just doesn't heal on its own. So I mentioned we treat things from head to toe. Some of the main ones are knee problems. We see a lot of patients with knee arthritis or ligament injuries or tendon injuries, shoulder arthritis and shoulder rotator cuff tears, knee ACL tears. We have good success treating tears of the ACL, the anterior cruciate ligament, provided that the tear isn't separated by more than a centimeter or so. So we're able to actually help patients with severe arthritis avoid knee replacement. That we know that from our Regenexx outcomes database. Our database would show that even patients with severe knee arthritis, the surgeon has said you're bone on bone, you need a knee replacement. Patients with severe knee arthritis are still considered a good candidate when we use the bone marrow procedure for them. So it works, like I mentioned, by helping your own innate healing, by helping the healing environment in your body to become healthier. With mild arthritis, we can actually help it prevent from getting worse, and we can treat meniscus injuries, and I mentioned ACL injuries. So we're currently tracking almost 20,000 knee cases in the Regenexx outcomes database as of a few days ago. So we track their outcomes. So 38% rate their patients rate their knee at the 38% improvement by 1 month. They rate 51% improvement by 3 months, and 61% improvement by 5 years. And then, because we ask them, what is your pain level? How much would you rate your improvement? And what's your function rating of different activities that you might do, like going up and down stairs or walking? And so 50 said, so if patients said, before you even have a procedure, if they would, on average, would rate their functionality as 56% of optimum. That increases to 66% by 3 months, 73% by a year, and 76% by 5 years. And that's a good point to bring out, is we do not guarantee that you are going to have 100% brand new feeling knee. What we show is that you will see significant improvement and significant improvements in your function, significant decreases in your pain, and help you avoid surgery. We do have some patients who, I mean, this is all statistics. So with any statistic, these are the averages. So they're going to be people who are higher performing or higher responders, and And there are people who are lower responders. I have many patients who will say, I have no pain whatsoever. I can't believe this. But we don't guarantee that, but we do stand by our outcomes data saying patients can get significant improvement, and it lasts for many, many years. Unlike things like a cortisone shot, you can get pain relief, but it causes damage to the joint, but you might get relief for 3 to 6 months. Or there's lubricant injections called hyaluronic acid. You might get 6 or 7 months of relief, but so it's a uh, lasting relief. So another thing I want to talk about is called intraosseous. That's the IO, bone augmentation. That's a more advanced treatment that we use for more severe arthritis, or in patients, even if they don't have severe arthritis, but if you get an MRI and they have bone marrow edema or bone marrow lesions, I mentioned that is often the precursor to rapidly advancing arthritis. So this is an MRI, and on this MRI image, the healthy bone would be dark, and swelling, such as joint swelling or blood vessels, is white. But this is bone marrow edema in the bone, and we can treat that and resolve that by doing an injection using a bone trocar, similar to what I showed, what we draw the bone marrow out of the back of your pelvis, but much smaller and skinnier. We can use that to actually guide it into the bone and inject right into that area of bone marrow edema. We use ultrasound to scan the area outside of where we're going to go to make sure there aren't any blood vessels or nerves that we might go through. We use conscious sedation and pain medicines. And there are numerous successful research studies, first done in France over 10 years ago by Dr. Philippe Hernagul, who is an orthopedic surgeon, who is one of the founders of using intraosseous techniques for bone marrow edema. So it's very successful, and in the last almost 2 years now, patients with moderately severe to severe knee arthritis, this is considered the gold standard for a Regenexx clinic. The standard of care is if someone has severe arthritis, let's say on the groin side, called the medial side of their knee, our optimum treatment would be to do the bone marrow stem cell type injection on the surface of the cartilage where it's wearing down, but also into the bone at the knuckle of the thigh bone, called the femoral condyle, and at the tibia, that's the shin bone. So these are some diagrams showing what does that look like. So on the far lower right, that's a diagram of one of the smaller trocars that we use actually in the knee. It's much smaller than the one to get it out of your the bone marrow extract in the first place. But over here on the left shows where one would guide it on the femur. This is a knee joint, and this shows on the tibia. That's the lower part of the knee joint, and the upper right. We can do this with a longer trocar to go into the hip joint if needed. So I mentioned we can help patients with ACL tears and other ligament injuries, and the things that we'll treat, patients could have a partial or a full thickness tear that is not retracted, meaning you've got a tear, but the ends are close together, or a tear with retraction where they're separated. And the first two we are able to treat. If it's full thickness and retracted, we recommend you have surgery. And again, these are pictures of treating the ACL, which I showed earlier. And we can also treat patients with moderate to severe shoulder arthritis to help avoid shoulder replacement, and for rotator cuff tears and labrum tears, as well as shoulder instability, the deep ligaments in the shoulder that help keep your shoulder in place and prevent it from shifting around. Patients can have an instability and kind of a sloppy shoulder, and we can treat that with guided platelet-rich plasma injections. So I want to just briefly address the whole issue of stem cell hype. And if you search online, you can see all kinds of books and seminars and clinics that are doing stem cell procedures. There are people who are promoting giving you stem cells through the IV, and there's a lot of stating that it can go through your whole body. And I won't get into the details on that, but suffice it to say, the data is very clear. If you have a problem in a given joint, you want to put those healing cells exactly where the problem is. But the big thing that I'm surprisingly, I still see a lot, and I hear some ads on, are the use of amniotic, quote, stem cells or placental tissue stem cells. And we'll talk about that in a second. But I just want to kind of address kind of the three phases that you can see when any industry or the medical field is adopting a new idea or a new procedure. And the first immature step is that, hey, this is magic, it works for everyone. And then next might be, well, this is great and it helps almost everybody. And then the more mature perspective would be, let's figure out who is a good candidate. And that's one thing we do with every patient in our clinic is you do a full evaluation. I spend at least an hour with the patient, usually more like an hour 15, maybe an hour and a half, depending on the complexity of the condition. And we really work out how good of a candidate are you. I mentioned that we use the Regenexx outcomes database to see who is a good candidate. That's kind of our main platform, our main starting point. And then we look at things like, what type of healing environment does your body have? Patients with numerous medical conditions heal a little less than patients who have no medical conditions. For diabetics, it's well known, don't heal as well. Your diet has a huge impact. Eating fast food, highly processed food, drinking sugared soda pop, all those are very, very pro-inflammatory and decrease your healing. So we spend a good amount of time looking at what's your current diet like, what supplements are you taking? There are numerous supplements that are helpful for healing and decreasing inflammation. We look at your diet and we try to guide you into eating more along the lines of the Mediterranean diet, which is very highly focused on vegetables and fruits, healthy oils such as avocado oil and olive oil, and healthy nuts, and a lot less, very limited red meat. And when you do have meat, the preferred meat is fish, and probably the next preferred would be chicken. But and part of the reason is there is great research showing that foreign animal proteins are inflammatory on our bodies. And the beautiful thing about fish, like salmon, for example, it may have foreign animal proteins, but it's got so much healthy omega-3 oils in it that that omega-3s decrease inflammation through your body. As a matter of fact, we recommend that patients take an omega-3 supplement. But anyway, that neutralizes inflammation. And so we really look at the whole body. How good of a candidate are you before we start talking about doing a procedure? So that's one thing we pride ourselves on, is really being upfront and saying, hey, we think you're a good candidate, or you're a fair candidate, or you're a poor candidate. I would be surprised if you got really good long-term results. And every now and then I am surprised. I'll find patients we think they're a poor candidate for a given procedure, and they'll say, I'm not doing surgery, I want to do the procedure. And some of them turn out well. But if someone, for instance, if someone has significant hip arthritis, beyond moderately severe into severe hip arthritis, our data shows that you have a very low chance of getting even 6 to 9 months of relief. So I'll say it. I recommend you get your hip replaced. So we'll be upfront with you on your candidacy rating. So, but the biggest thing that we see, and I'm surprised that we still see it because there's so much data about it, is people advertising doing stem cell injections using amniotic fluid or placental or cord tissue. And the reason why that's an abuse is these are cells from another body. They're not your own cells. Everything we do, we take from the patient's body, we process it. We're on site, it never leaves our clinic, and it's injected back into the patient within 24 hours. It's done that same day. If you're taking cells from placenta or cord blood or any of these other tissues, they have to be sterilized in order for anyone to sell them and to safely inject them into a patient. So if you're sterilizing these cells, the cells aren't alive anymore. They've been sterilized, they've been killed. So there are numerous studies showing that these injectable tissues are dead tissue. They can have growth factors in them, but even that has been studied, and the amount of growth factors that are in the placental type products are lower than if you had just drawn blood out of a patient and injected just whole blood into their problem. So if anyone is advertising, we're doing these, amniotic injections, walk away. As a matter of fact, that's actually regulated by the FDA as dead tissue products. So that wraps up what I wanted to talk about tonight, and I'd like to open it up for questions. If anyone has any questions, you can put them in the chat, or you can pipe in, or you can always send me an email. I'm going to put up the contact information for the Regenexx clinic and our address, and I want to highlight the website down below. It's Regenexx with 2 X's, Moines.com, and on that website we have forms, or if you're thinking, gee, am I a candidate for a procedure? You can fill out the form. There's questions that will be asked, and we have a team that actually fields all these questions and contacts you, and can help get you set up with an appointment. And so there's a question. So a medial tear can be healed with this injection therapy. And I'm assuming, and that's from Sarah, and I'm assuming you're talking about like a medial meniscus tear, I think. And so generally I'd say yes. Now there's a caveat would be people are often told, oh, you have knee pain, it's because you have a meniscus tear. Meniscus tears can be the cause of your pain, especially in a young person who's had an acute injury and they've twisted their knee and they have a clear-cut tear of the meniscus. In most cases, it's part of the extension or part of the whole spectrum of issues surrounding arthritis of the knee. So, for example, even without an MRI, if I get an MRI of pretty much anyone age 50 or older, I will see meniscus tears, or meniscus degeneration, and the patient might not have any pain whatsoever. For example, if we got x-rays, just plain x-rays, and if you look at the x-rays and it looks like there's a little bit of narrowing of the space between the bones, looks like you have mild arthritis, you have a 50% chance of having a degenerative meniscus tear. If the x-rays look like you have moderate arthritis, there's about an 85% chance that you also have degeneration of the meniscus. And if it looks like severe arthritis, guaranteed the meniscus is probably shredded and flattened and is not there. So generally when patients, so the meniscus, for those who have not heard of that, the meniscus is a horseshoe shape, shock absorbing pad made out of fibrous connective tissue and cartilage that sits in between the knuckle of your thigh bone and your shin bone. And we have one on the inside of the knee called the medial meniscus, and one on the outside of the knee on the lateral aspect called the lateral meniscus. So patients can get tears in there. And so when I'm treating a patient with arthritis and they have meniscus tears, I inject into the meniscus as well. So it's kind of a roundabout answer to the question, but if someone has a meniscus tear, chances are you have some other things going on. And so I would also treat those other things, such as any laxity in the knee that might be involved with the ligaments that hold the knee in alignment, and definitely the arthritis. There's a question that says, in regard to a knee injection, I am bone on bone and advised to have replacement surgery. At age 71, what result would you expect from the Regenexx injections? So like I mentioned before, severe arthritis from our outcomes database, patients are still considered a good candidate if we're using the stem cell bone marrow procedure. If we only did a platelet-rich plasma procedure, you'd be considered a poor candidate, meaning you might get, 6 months of relief, maybe 9 months of relief, but not years of relief. So we routinely have patients who are told they need knee replacement surgery, and typically they're older. So there's been some people have heard that, well, the older we get, we don't have good bone marrow, we don't have stem cells, so it doesn't work in older people. That's not the case. Our outcomes database, we've got patients in their 80s and 90s who with severe knee arthritis who have done well. So that said, if someone has bone-on-bone arthritis and you have severe arthritis, I mentioned earlier, our standard of care would include the bone augmentation, which is an additional step, but it's done on the same day that we would normally do the stem cell type procedure. So yes, patients with severe arthritis are still considered good candidates. So, and that brings up a point. So Regenexx, with our outcomes database, we've been able to show how well we can help people avoid surgery and avoid joint replacement and rotator cuff surgery. And so over the last several years, Regenexx has been approaching companies who have who are self-insured with their insurance, their medical insurance, meaning they provide medical insurance to their employees, and they are the insurance company. Some of them are really, really big companies like XL Energy, Hy-Vee. There's anyway, Regenexx has approached new companies around the country saying, look, here's our data. We can help you avoid surgery. We can help reduce your costs to your company by doing Regenexx procedures rather than surgery. And about 5 years ago, there was probably 300, maybe 400 companies around the country that said, yes, we will provide Regenexx only regenerative medicine treatments to our employees to help avoid surgery. In the last 4 years, that's grown to over 2,000 corporations. So because patients often say, well, insurance doesn't cover this, but will they ever cover it? And I tell them, check with your employer. If you're still employed, your employer might actually cover this because Regenexx outcomes have shown that you get longer relief, and it can avoid surgery. And so my point there was we are helping companies around the country to reduce their medical costs by avoiding surgery. And many of them are patients with bone-on-bone knee arthritis. All right. Hopefully that answered it for you. Another question, do you recommend starting on stem cell therapy while in the middle of a class of isotretinoin? I've had an increase in the joint pain, wondering how much is due to that. We'd have to look at it on a case-by-case basis. If you're taking that for rheumatoid arthritis, we'd have to look at just how well your rheumatoid is controlled. Up until about a year ago, we used to say that patients are not a candidate if they have rheumatoid arthritis, and that has been shown recently. We've been shown that actually, at least with platelet-rich plasma, that patients with rheumatoid arthritis actually respond very well. Another question was, can stem cell therapy help advance arthritis, such as in the great toe? Yes. So I've had patients with arthritis in their thumb, arthritis in their toe. Many of them, with severe arthritis, let's say at the base of your toe, in most cases, we'll say, you know, you could try a very concentrated platelet-rich plasma injection and see if you can get years of relief with that. If you only get 9 months or 12 months, then step up to a bone marrow stem cell type injection. But we've had good success with finger arthritis, toe arthritis. So what is the cost of the procedure for severe hip pain? Do you do MRIs and or x-rays? We do x-rays on site. That's considered part of the cost of your evaluation. Your regular evaluation, like the office visit, which like I mentioned is usually about an hour or an hour and a half, is covered under regular insurance. If not, there's patients will pay out of pocket. It's usually a couple $100s. We do not do MRIs, but we'll order them at any facility that is convenient to you. And then the cost of the procedure, it can really vary depending on whether you're doing a platelet procedure or a stem cell procedure. And when we go through an evaluation with a patient and we come up with a treatment plan, we have you sit down with our patient care coordinator to work on what are the costs around that, what is the timing around that. And so the question about the isotretinoin, yeah, I forgot that's an acne medication, not an immunomodulator. So isotretinoin for acne would probably not be an issue at all. We have a list. We have a list of medications that we go through with the patients to see if you need to pause or stop it. And I don't have that in front of me. It's on our website. We have this list of different medications that we want patients to stop because our Regenexx research labs in Colorado they're able to grow cultures of stem cells and grow them and then expose them to different medications and see which prescription medications inhibit or stop stem cell growth. And they do the same thing with all the different supplements available on the market and see which different supplements will cause your stem cells to be more active or which ones don't do anything. And so we have a list of different prescription medicines that for patients doing a stem cell procedure, we'd ask them to stop sometimes 2 weeks before a procedure and stay off of it for maybe 4 to 6 weeks after. Some of them are longer. So for instance, if you've had a steroid injection or if you're taking oral steroids, those inhibit platelet activity and inhibit stem cell activity. So we'd say we will not do a procedure till it's been at least 6 weeks after you've been off of steroids. So all the different medications, we have different guidelines that we go through with you to see if you're still safe to take it. Let's see. And question is, will this help neuropathy in the feet? The quick answer, probably not. So if you've got neuropathy in your feet, neuropathy means the small nerves so nerves start out, imagine like a tree. You have a trunk, and then as it grows further, you break into branches, and those branches have smaller branches and smaller branches. So same thing happens with nerves in your body. You start with a big nerve root, and it meets up with other nerve roots in your spine, and they come out as a big nerve going, for instance, down your leg. And as that nerve travels, it breaks into smaller and smaller branches. And neuropathy generally is a problem with the very, very little end nerves that are not functioning properly. And so it's not like I can go in and inject a treatment into all of those little tiny nerve endings. If you have a problem called mononeuropathy, where the actual nerve is being impinged, for instance, carpal tunnel, you have a nerve called the median nerve, and it makes your fingers go numb or painful. But that nerve problem is caused at your wrist. We can treat it if it's a mononeuropathy, but if you've been told, well, I've got peripheral neuropathy or idiopathic neuropathy, that's more of a metabolic whole body type problem. And that's not something that an injection is going to help. So it depends whether it's due to impingement of the nerve going into your foot or if it's due to all the little tiny nerve fibers. All right. Well, thank you for all of your questions. We're just about ready to wrap up. Again, I'd like to guide you to that Regenexx Des Moines website, Regenexx with two X's, DesMoines.com. And on there should be more information that you can look up. And you also, if you're interested in being evaluated, there's a form that you can put your information in, and you'll be contacted to discuss whether you're a candidate and to get you into our clinic. So thank you very much. Have a great evening and enjoy the springtime moving forward.